Hello everyone. This video will talk about the different non-malignant disorders of leukocytes. The leukocytes, or white blood cells, function to protect the body against invasion by foreign organisms or antigens, and in doing so they undergo visible changes, and these changes may either be a reactive change or a toxic change, and these types of changes can be evaluated microscopically in the clinical laboratory. These changes are generally subdivided into quantitative variations where there is an alteration in the number, or a qualitative variation where there is morphologic alterations. So therefore, each type of white blood cell, we have the neutrophil, eosinophil, basophil, monocyte, and lymphocyte, may either have a quantitative or a qualitative variation. Let's first discuss the different quantitative abnormalities of the white blood cells. To discuss quantitative abnormalities, it is necessary to define the different reference ranges, or the reference intervals, for the white blood cell count and the different types of white blood cells. It is also important to remember that these reference ranges may vary in between laboratories because of the following: because of the different cell counting procedures, or the instrumentation used in the laboratory, or the methods used to establish these reference values. Also, different reference values may also be given to different patient populations. So for the sake of this video discussion, we will be following the reference ranges set in Rodak's hematology book. These are the different terms important in quantitative variations. Leukocytosis is defined as a leukocyte count of adults of being greater than 11 expansion 9 per liter, and this may be caused by the increase of one or more of the following cell types, like an increase in neutrophils or neutrophilia can cause leukocytosis, or an increase in eosinophil or eosinophilia may also cause leukocytosis. Leukopenia, on the other hand, is defined as having a white blood cell count of less than 3 expansion 9 per liter, and this may be caused by a decrease in the lymphocytes or the neutrophils. Eosinophils, basophils, and monocytes individually do not produce leukopenia because they are normally low. Pancytopenia, on the other hand, is the term given when there is a decrease in all of the different cell types. An increase in neutrophils above 7 in adults is referred to as neutrophilia. The normal relative neutrophil count is approximately 50 to 70%. And the three main causes of neutrophilia are infection, inflammation, and malignancy. Neutrophilia may either be pathologic or non-pathologic. Pathologic causes may be infections, inflammatory response, or drugs. Bacterial infections, especially those caused by cocci, may produce striking neutrophilia. The degree of neutrophilia by infections depends on the virulence factor of the organisms as well. And we can also consider the age and the health of the patient. Children develop more profound neutrophilia compared to adults. The term leukemoid reaction refers to a reactive leukocytosis of above 50 white blood cells. This causes a shift to the left where there is the presence of immature neutrophilic forms. A leukemoid reaction usually refers to the increase in neutrophils, but there may be an increase due to the other cell types of leukocytes as well. A neutrophilic leukemoid reaction may be confused with chronic myelogenous leukemia. Neutrophilia will have toxic granulations and Dola bodies, while CML will have pseudo-Pelger-Hewitt cells. Leukemoid reaction will have normal platelet morphology and number, while CML will have an involvement of platelets and may be increased. Leukemoid reactions would have an increased LAP or leukocyte alkaline phosphatase score. CML will have a decreased LAP score. The term leukoerythroblastic reaction refers to the presence of immature neutrophils or blasts, nucleated red blood cells, and teardrop cells in the same blood sample. Leukoerythroblastic reactions point to the possibility of space-occupying lesions in the bone marrow like metastatic tumor, fibrosis, lymphoma, or leukemia. A leukoerythroblastic reaction is also strongly associated with primary myelofibrosis. Neutropenia refers to a decrease in the absolute neutrophil count of below 2 expansion 9 per liter. Neutropenia is the most common cause of leukopenia. The term agranulocytosis is used to designate extreme neutropenia, and this refers to a neutrophil count of less than 0.5 expansion 9 per liter. Profound neutropenia generally renders the patient vulnerable to infection. The risk of infection increases as the absolute neutrophil count decreases. A decreased production of neutrophils may be either inherited or acquired. Inherited forms of neutropenia are rare and include a variety of poorly understood syndromes. The acquired forms of decreased neutrophil production are common. Destruction of the stem cell compartments generally results in hypoplastic or aplastic marrow, which will decrease the different cell types. The second major category for neutropenic states would include those that are caused by an increased neutrophil destruction due to infections, immune mechanisms, or hypersensitivity states. Any infection that overwhelms the marrow's capacity to produce adequate numbers of neutrophils will result in neutrophils being consumed or recruited to the tissues faster than they are released by the marrow. Typhoid and brucellosis are bacterial infections commonly associated with leukopenia and neutropenia. Viral infections characterized by neutropenia include measles, yellow fever, infectious hepatitis, infectious mononucleosis, and rubella. Eosinophilia is defined as an absolute eosinophil count of above 0.4 expansion 9 per liter. The most causes of eosinophilia can be divided into two categories, and these depend on the geography. In underdeveloped areas, parasitic infection or infestation, especially helminths and protozoa, causes eosinophil counts to increase. While in developed countries, eosinophilia is most often associated with allergic conditions like asthma, hay fever, and atopic dermatitis. Eosinopenia is defined as an absolute eosinophil count of less than 0.09, and this can be very difficult to detect because the normal eosinophil reference range is very low. Eosinopenia is most often associated with conditions that result in marrow hypoplasia or infection or inflammation that is accompanied by neutrophilia. Basophilia is defined as an absolute basophil count greater than 0.15. The most common cause of basophilia is the presence of a malignant myeloproliferative neoplasm such as CML or chronic myelogenous leukemia. Non-malignant causes of basophilia are rare and include allergic rhinitis and hypersensitivity to drugs or food. Basopenia or basocytopenia is associated with a deficiency of basophils. The decrease in the number of basophilic granulocytes in the circulating blood can be defined as less than 0.01. This may be very difficult to evaluate due to the small and variable number normally present in blood. Flow cytometry is used to detect basopenia. Common causes of basopenia include acute infections, stress, hyperthyroidism, and increased glucocorticoids. Monocytosis is defined as an absolute monocyte count of greater than 1 expansion 9 per liter. Monocytosis is associated with a wide range of non-malignant conditions and also with neutropenic disorders. Monocytosis is frequently the first sign of recovery from acute overwhelming infection or severe neutropenia. An example of this would be after cancer chemotherapy. Monocytosis in these conditions is considered as a positive sign of recovery. As mentioned earlier, monocytosis is associated with a wide range of non-malignant conditions because of their participation in, for example, acute and chronic infections like tuberculosis and malaria. Other immunologic conditions may also cause an increase in monocyte count like systemic lupus erythematosus and rheumatoid arthritis. Certain hematologic conditions like Wiskott-Aldrich syndrome and chronic neutropenia may increase monocyte count. Drugs like valproic acid may also cause monocytosis. Patients who have cancer like lymphoma and other carcinomas may also increase monocyte count. And lastly, stress caused by trauma may also cause monocytosis. Monocytopenia is defined as an absolute monocyte count of less than 0.2. This is very rare in conditions that do not also involve cytopenias of other lineages. Absolute monocytopenia has been found in patients receiving steroid therapy, hemodialysis, or patients with sepsis. Viral infections, especially those due to the Epstein-Barr virus, can cause monocytopenia. Lymphocytosis in adults is defined as a count greater than 4.5. It can be subdivided into those with and those without reactive morphologic alterations. Causes of reactive morphology are usually viral infections like CMV, HIV, and hepatitis, although other bacterial infection may also cause an increased lymphocyte like typhoid and syphilis. An example cause for non-reactive morphology would be whooping cough caused by Bordetella pertussis. Adult lymphocytopenia is defined as a count below 1 expansion 9 per liter. Non-malignant causes of lymphocytopenia can be subdivided into inherited and acquired. A decreased lymphocyte count may be seen after infections like influenza and herpes, or as a side effect of therapy like chemotherapy and radiation. It may also be secondary from certain systemic diseases like Hodgkin's lymphoma and carcinoma. Or it may be a simple nutritional deficiency that can cause a decreased lymphocyte count. Let's take a look at a sample CBC result or a complete blood count result. On first inspection, we can see that the white blood cell count, which is 13.6, is elevated. And when a leukocyte count is more than 11, as mentioned earlier, this would mean leukocytosis. But it is important to determine which of the following cells are causing the increase in the white blood cell count. So we have to examine the relative counts. But in this case, the cells are all within the reference limits. Therefore, there is no indication as to which of the cell lines could be causing the increase in the total number of white blood cells. What we have to do next is to compute for the absolute count. Absolute counts are computed by multiplying the relative counts, which are in percent, to the white blood cell count. The absolute numbers in this result indicate that the neutrophils are elevated. This would mean absolute neutrophilia. This would also lead the physicians that a bacterial infection is likely causing the increase of the white blood cells. If, for example, the lymphocytes were the ones increased, then a viral infection is most likely the probable cause. Let's now proceed to the different qualitative abnormalities of leukocytes. Qualitative variations may or may be pathologic. The neutrophil qualitative variations may be divided into two: those with morphologic abnormalities and may or may not have functional defects, and those with normal morphology but with functional abnormalities. Let's start with the different leukocytes with morphologic abnormalities, which may or may not have any functional defects. We will go through these briefly since these were already included in the previous video. The first one is the Pelger-Hewitt anomaly, which is described to have a decreased nuclear segmentation in neutrophils. This may also affect other white blood cells. Neutrophil hypersegmentation would have more than 5 nuclear lobes in neutrophils. Alder-Riley anomaly will have granulocytes containing large, darkly staining metachromatic cytoplasmic granules. Shediac-Higashi disease will have giant lysosomal granules in granulocytes, monocytes, and lymphocytes. May-Heglin anomaly will have DOLA-like inclusion bodies in neutrophils, eosinophils, basophils, and monocytes. Let's now proceed with the qualitative abnormalities with normal morphology but with functional defects. The first one to be discussed is chronic granulomatous disease. CGD, or chronic granulomatous disease, is caused by a mutation in the NADPH oxidase genes, which leads to the failure of the neutrophil respiratory burst following phagocytosis. Normally, a neutrophil will phagocytize a pathogenic organism and will kill it with the phagolysosome. But CGD is a condition in which phagocytes ingest successfully but cannot kill catalase-positive organisms because of the lack of an appropriate respiratory burst. This then leads to the formation of granulomas. CGD, or chronic granulomatous disease, is also known as Bridges-Good syndrome or Quay syndrome. The respiratory burst can be evaluated by nitro-blue tetrazolium reduction in the phagocyte. A yellow water-soluble dye, NBT on reduction, is converted into an insoluble blue formazan. Normal activated phagocytes would reduce the NBT with the presence of the peroxide they generate in the respiratory burst, therefore giving a blue color. CGD patients are unable to reduce the NBT, therefore retaining the original yellow soluble color. The second qualitative abnormality is leukocyte adhesion disorder. This is a type of defect in neutrophil migration. The recruitment of leukocytes to the site of inflammation involves the capture of leukocytes from the peripheral blood, followed by the rolling along the blood vessel wall. This process is mediated through selectins, which interact with their ligands on the leukocyte. In LAD, there is a defect in selectins and/or the integrins. That results in the inability of the neutrophils and monocytes to adhere to the epithelial cell and to transmigrate from the blood to the tissues. That means that the white blood cells cannot reach the site of tissue injury or inflammation. There are 3 categories for LAD: LAD 1, 2, and 3. The third qualitative abnormality is Job's syndrome, where there is an impaired directional motility. The random movement of the phagocytes is normal, but the directional motility is impaired. What happens is that the cells respond very slowly to the chemotactic reagents. As a result, the bacteria have more time to multiply in the tissues before they are attacked. This leads to the occurrence of infections and sepsis. Like in the biblical Job, the patients suffer from persistent boils and recurrent cold staphylococcal abscesses. These abscesses are described as cold because the usual signs of inflammation like heat and redness are absent. Patients also have a markedly increased level of IgE. The next one is the lazy leukocyte syndrome. This syndrome is a rare condition in which, as the name suggests, both the random and directed movements are defective. There is a defect in neutrophil chemotaxis. They cannot migrate to the site of tissue injury. The cells have normal phagocytic and bactericidal activity, but they fail to respond to the inflammatory stimuli. The bone marrow contains normal neutrophils, but patients have severe neutropenia because the cells are unable to migrate from the marrow to the peripheral blood. Ultrastructural and biochemical studies suggest that the cells in lazy leukocyte syndrome contains defective actin filaments that are closely associated with the cell's ability to form pseudopods and move. The last of the neutrophil qualitative abnormality are miscellaneous granulocyte disorders, an example of which is the MPO deficiency. This is characterized by the deficiency in myeloperoxidase in the primary granules of neutrophils and the lysosomes of monocytes. Myeloperoxidase normally stimulates the production of hypochlorite and hypochlorous acid, which are oxidant agents that attack phagocytized microbes. A decrease in the MPO or a deficiency in the myeloperoxidase will lead to a decrease in intracellular killing because of the absence of bleach. Hypochlorous acid is 50 times more potent than hydrogen peroxide. The defect originates through the mutation in the MPO gene on chromosome 17. Eosinophils exhibit some morphologic alterations that reflect activity and not an abnormality. Degranulation is probably the most prominent eosinophil alteration. Vacuolation is seen occasionally. The vacuoles tend to be quite small, and their significance is unknown. Hypersegmentation is the only relatively common nuclear alteration in reactive eosinophils. Since normal eosinophils have only 2 nuclear lobes, eosinophil hypersegmentation is defined as 3 or more lobes. There is little about basophil morphology during reactive conditions. Degranulation is the single morphologic alteration that may be detected. Degranulation may be seen after ingestion of a fatty meal or as a consequence of an antigen-related stimulation. A few morphologic expressions in monocytes may be considered reactive. These changes in appearance reflect the basic monocyte responses to stimuli like the transformation into histiocytes, macrophages, or epithelioid cells. Another reactive change happens during infections or during recovery from bone marrow aplasia. This is when the nucleus becomes thin and band-like in areas and may appear to be segmenting. The pathologic qualitative abnormalities of monocytes and macrophages are lysosomal storage diseases, and these can be subdivided into the MPS and the lipid storage diseases. The MPS, or the mucopolysaccharide storage diseases, also called as the mucopolysaccharidosis, are a family of inherited disorders. The MPS have been subdivided according to which enzyme is defective. Examples would be Hurler syndrome and Hunter syndrome. The lipid storage diseases are inherited disorders in which lipid catabolism is defective. Examples would be Gaucher disease, Niemann-Pick, Fabry, Tay-Sachs, and Sandhoff disease. And lastly, we have the qualitative variation for lymphocytes. Over the years, reactive morphologic changes in lymphocytes have been described using various terms. This includes reactive, Turk, Downey, and so on. Among all of the different terms, atypical is commonly used. And that ends this video lecture about non-malignant leukocyte disorders. Make sure you watch the white blood cell disorder overview and the malignant leukocyte disorders video. Thank you for watching.